how those are looking at this time. And so with that in mind, combined with working with our consultants and with the different scenarios that we had studied and looked at with modeling, and in consultation with peers across the country, as each of us are dealing with it in our own way, but in similar ways, and the challenges that are there, a number of steps were taken. But before we get into those details about what the media announcement this morning was on that, I'm going to ask Dr. Yaffe to talk about some of the numbers as we see it and how that's evolving and what direction it indicates that we're moving in at this time.
Okay, thank you. So as of this morning, we have a total of 186 cases of COVID-19 in Ontario. And of those, about 92% are either related to travel outside of Canada within the 14 days before onset of symptoms or close contact of a case. Just dividing it up, about 3/4 are travel. And of those who traveled, the data showing at this point 29% of them traveled to the United States. The most common states visited included New York, Colorado, California, Florida, Nevada, and Massachusetts. This does not include the data from Trenton, where, as you know, we have the repatriated people from the Grand Princess Cruise. We have a total of 9 positives there, of whom 3 are Ontario residents. The good news, if there is any, is that the Public Health Ontario lab has been able to modify their testing methodology, and they are now able to test almost 2,000 samples a day, which is a very good improvement. We're still working toward having a capacity to test 5,000 a day in Ontario. So at this point, there are, as I said, 186 positives. They have actually tested 9,415 who are negative, and there are a significant number that are still under investigation. So, and as well, we are trying to speed up the criteria we use to resolve a case. So there's a lot of work happening at the lab. There's a lot of work happening out in the field to get these numbers as current as we can for you.
Yeah, thank you. And so as we're progressing in this and we see the aspects there, we understand that a lot of people are anxious, some a bit scared, some people are very much focused on the aspect there. And what I said this morning, I agree again, is that I found for overall the Ontarians are responding well in handling this crisis and information. It may surprise some of you that when we were talking on coming up in SARS in 2003, I was leading the ministry's public health response for SARS, and I had to keep talking to the lead of infectious disease at the Toronto Public Health then, Dr. Barbara Yaffe. And so we were very much involved in these and other major outbreaks. And during this time, it's very important that we have a combination of consistent messaging, proper, timely messaging, and to inform the public who we need to engage with and who we want to have their participation to undertake these steps we're asking today. And we want to inform you so that one doesn't have to be scared, one can be aware and know what's happening. And that's our job, is to try and keep you informed as best we can in that regard. And in light of that, we were making recommendations as we saw the numbers increasing. As I said before, while we have done strong work with containment during our first while, as we talked about before, with the Wuhan and Hubei province outbreak and its impact on Ontario, knowing that we were getting 5,000 people a day throughout December and January coming back and forth into a large community here in Toronto. And without that containment, we would have expected that we could have gone somewhat towards the Italy type perspective. But that containment was worked aggressively at by public health, and we moved on. And we did the same with Italy and the Iranian situation as well. But now we face a different challenge. And with the amount of cases we're seeing, with the number of Ontarians returning to Canada and testing positive, and the amount that's going to come, we have a new challenge ahead of us. And therefore, besides our containment work, we had to add social distancing. We had some messages in there before, as you're aware, but we had to go to more extensive social messaging and to ensure that the period, as I said back a week ago, when these next 2 weeks and 4 weeks were going to be very important, we didn't know how fast it would rise and pick up on. And it rose up very quickly. And if you're going to do these social distancing activities, you can't do them after the fact. You have to do them ahead of the time. And I did suggest and recommend a number of things yesterday afternoon. And when I say that is, we talked about the different venues around size, 50. We talked about activities such as bars and restaurants. We talked about social gatherings and groups and different things there. And we outlined those. And it was important in those are recommendations. Those are not, the powers are not there directly to do that. And the Premier today declared a provincial state of emergency. Why was that done? One is that we need to have a response, and I was very pleased that the Premier and the Cabinet took this responsibility because it does increase the powers and ability to move on action and to deal with that in an assertive way. It does allow a lot of different aspects for them to undertake and to demonstrate, as the Premier has, strong leadership to continue to protect the citizens of Ontario. So it's not a heightened emergency state in that sense, but it is a heightened state of emergency response by the provincial government. And that is important because it's an important adjunct to the recommendations I've made, and that would ensure an ongoing safety and the health of Ontarians in that light. So these measures that were put in there, we didn't take them lightly, and the Cabinet, of course, doesn't take those lightly, as you heard from the Premier today. And they're things that are meant to protect. I found for the most part, people are already asking, why is this not occurring? Why are you not closing this and doing that? And this basically has ratified for what a lot of the public say, this makes sense to me. And while it may be upsetting to some, and it may be upsetting your normal lifestyle for a period of time. And I think in that sense, it's like when one is preparing for natural events, like say natural storms, hurricanes and that, one looks at the data, one gets advised by experts, and one starts to predict and see what could happen. You don't wait till it comes, you start preparation ahead of time. If you do that in a normal, common state, then you're ready for when that event occurs. We looked at the data, we had our experts from PHO, we had other academics, we had our modeling people, and they say, this is coming. You need to do something. You need to ensure, if you're going to do social distancing, you need to do it now and you need to do it effectively. And that, like, we did the emergency measures action to help ratify that, especially because we didn't want massive gatherings that could compromise right out the door our response to the issues. And I think it's important that we know it's a timely one, but it's also a time-limited one. So we want to see, especially as I said before, we need to be doing this very assertively over the next 2 to 4 weeks, especially as we deal with this issue. And so it's that engagement of the public-wide community in that, and we'll talk about that in a moment, all the different steps that one can undertake. So in the declaration, we did talk about all facilities providing indoor recreational programs. We talked about all public libraries, that they would close immediately, all private schools as defined in the Education Act, all licensed child care centers, all bars and restaurants, except to the extent that they could carry out people with takeout or delivery, and all theaters, including those offering live performances of music, dance, and other art forms, as well as the cinemas that show movies and concert venues. And there's other things that the Minister, the Premier, and the Minister of Finance and the Attorney General talked about that helps to equip the province in outside of health issues that are very critical, because it's not health only. There's aspects around jobs, aspects around economic relief, etc., that are all important to maintain that our citizens of Ontario stay engaged wholeheartedly in this aspect, especially conservatively over the next 2 to 3 weeks. And so we've undertaken that. So in that light, we have to watch now. And we're doing our lab testing. Our command table is doing many activities at this time. They're ramping up the assessment centers, the number of assessment centers and the location of the assessment centers. We're trying to relieve what was increasingly some load on the emergency departments so that they have some flexibility and more room in case there is a larger event and they have to respond to it. We're trying to look at how do we get more beds and services? How do you have more different products and materials? Continually searching for issues around the fulfilling and actually stockpiling. How do we get more PPE and all different things? All these components are vital and critical, and there's many parts and components of the command table working on those aspects right now. What are the rules around people returning? What are the methods of isolation? What is self-isolation? How should one do it? How does one do it if one is asymptomatic? How does one do it if one is symptomatic? What does one do if one is actually proven positive? And what advice are we going to give in that area? How does one go about finding out what they are? And with our self-assessment form, that when the first night we put it out, it had 94,000 hits. And these are things that equip Ontarians with the information they need at their point of need to get it answered. And if it can't be answered, then we got to pick up ours. We're doing our telehealth system was loaded down. We've added a whole bunch of more staff onto that, as well as we're trying to make our public health units more staff to be reallocated to deal with the many calls and concerns from you, the citizens of Ontario, so that you can be informed and continue to be fully engaged in this response. So with that, I'd like to open up for questions on that, and in there.
People that there aren't enough tests or that testing has become a lot more restrictive. Can you just go over what the criteria is now to get tested?
You want to take that one, Barbara?
Well, first of all, I think the most important thing to keep in mind is we do not want any people tested who have no symptoms. And I think certainly up till recently there have been a large number of what we would call the worried well who wanted to get tested, and I can understand that, but the test is of no use if you have no symptoms. In terms of specifically who, it then becomes a clinical decision in terms of how ill is the person, what are the symptoms, do they have a history of travel, have they been in contact with someone, is there something clinically that makes the physician or nurse think that they might have it. And also we're working with Public Health Ontario to come up with more clear criteria, things like if it's a healthcare worker, and things like that. So right now, the most important thing is they have to have symptoms.
Can you clarify how many new cases are in Ontario today? And in the past few days, we've seen that number go up by 30-something, 40-something. Today, we're looking at, is it 8 or 9? How significant is that, and why do you think that is?
Why did it go down?
Why did it go down? And also, if you can clarify, I think there was some confusion as to whether there was 8 or 9 new cases.
Well, I think if we include the death that Dr. Williams mentioned, it's 9. But that person was considered a person under investigation before. So they were already in the numbers, so to speak. Why is it less? It's hard to say, but there is a significant number of specimens that are still under investigation. So it's partly because unfortunately the lab has been there's been a lot of specimens coming into the lab. And as I said, their capacity has been increased. So hopefully the number that are pending will be going down so that we'll know more about these, whether they actually are cases or not.
So in the last 24 hours, do you believe that testing or the confirmation was slower than other days? Is that what you're attributing it to?
I don't think it was slower. I think there might have been more specimens, so to speak, backing up. Because right now, I was just looking at this morning's data, there are 1,566 under investigation. That's a pretty large number. So.
And they received another 1,000 samples. So it'll have its bits of ebbs and flows. Mm-hmm. We'll probably have quite different numbers again tomorrow.
So this number isn't of significance to you looking at that. You don't see this as a downward trend.
I wouldn't take it. I wouldn't. It may be nice to think that could happen that quickly. We've learned from many experience that those are little dips, and we need a lot more data before we feel there was an indication of any trend direction. in either direction. So we're just getting into this, so we have to watch that.
People are getting turned away from assessment centers, even if they are exhibiting symptoms. They're being told, well, you're not 60 plus. So has the criteria changed? Because we've heard from numerous people that they're being told, just go home, even if you're exhibiting symptoms, you're not of the age where we want to test you. So has anything changed, and how do you respond to that?
We are working on, with Public Health Ontario, to develop some clearer prioritization criteria. They should not be turning away people who are under 60. It's true that people over 60 are at higher risk of complications, but that doesn't mean people under 60 aren't at risk.
San Francisco has, public health officials have issued a shelter-in-place order to their citizens. Apparently, New York City is considering something similar. What does that say to you as public health officials about the state of COVID-19 in the United States, especially when you consider how many thousands of snowbirds and other travelers are returning to Ontario from the United States?
We've asked about three parts of that question. The concept of shelter in place, and that's what we're doing here in Ontario anyways. We want people to stay at home. And that's our modus right now. Stay home, stay informed, stay healthy, and stay calm as you go about that. Because all these things are within your realm to protect you and your family members by doing all those things in that light. And much like we gave the analogy with the weather systems, you do that for a period of time and then you wait for the storm to pass. In that light, as far as how it affects our aspect with our citizens who go down and spend time in the United States, various areas, we understand quite a few we hear are returning in light of that, and we have to be aware of that, and that's what I said is the concern. Have some come in contact with COVID-19 without knowing, so this is a large assessment. That's why they all come back in. They're all going to be under the federal travel advisory of requiring isolation. And most of my hope are going to be coming back asymptomatic. And then we monitor them, and they do the intensive self-monitoring. They do the home, there's different terms for it, but they set up on that, and they make sure they have enough there and supplies, and they do that, I would say, diligently for a period of time for the 14 days. And if they do develop symptoms at that time, then they're supposed to, they can try the self-assessment tool. You read that, and then it gives you direction, what they're called telehealth, and they direct you on from there. So if you look at some of the different risk exposures, it's hard to say what they've been exposed to down there or not, which states are more problem than others. California is different than others, so we have to do that. And I think the other aspect is you see some of them in high-risk things. We didn't mention our Trenton people. They're still there, by the way. And we've now gone up to 12 positives, 9 of which are Ontarians in that. So they were exposed. When they came, they were all presumably nearly asymptomatic, except the one who got sick on the flight, so that they were in a risk area, and it's now mid-range through their exposure period, 8, 9, 10 days, and they have a number of them have turned positive. So it tells you that while they may come back asymptomatic, they could convert depending on their risk exposure. And so we want to be aware of that. And when you look at numbers like that, there's estimates of anywhere from 2 to 500,000 that can be coming back at different times. So that's a job. That's a task. And how do we undertake that? How do we give them the supports they need? How do we make sure they're getting the right advice and we understand that so that they don't pose a risk to themselves or their friends and others, and we monitor them for health issues. So there's really 3 parts to your question. They're all important, and that's another part of our Ontario community that we're working to deal with.
Doctor, what do you feel about, or given that Barbara Yaffe mentioned earlier that 29% of the travel-related cases are from the States, how do you feel about the border still being open with the United States?
Well, that's a federal decision. We were going to be on the federal committee today. We have one of our other doctors doing it because they delayed it until this time, so we're going to have to miss it, and to see if that's raised as an issue. They made a decision to say that visitors other than Americans will not be allowed through at this time. Whether that would change or not in the future, I'm not sure. One of the aspects is there's a lot of back and forth movement with trade and supplies and materials that are critical to maintaining the essential services here in Ontario, and that was very much important to the Premier and Cabinet. They did not want to compromise that and how we would do that. So I think there's some aspects there.
Like, since they've blocked other foreign nationals, if you were wearing that big hat, would you say we should keep Americans out? Or is that going too far?
I'd like to understand it because we have a very unique relationship with our neighbors, and we want to make sure we exercise that well. Look at all the people that spend extensive lengths of time down there, and so we have to allow all those people to come back as well. So I think it's something that we have to understand better and how it works. And there may be some undertakings. They may say a certain state they're going to limit movement in and out of. For example, they went into their own volition. So we have to keep in partnership with our counterparts down there in CDC and the federal government working with the American government as well as with our Public Health Agency of Canada. So it's a complicated question, and I'd say at the moment we haven't seen that I'm aware of testing any number of, or I don't know if we're testing any Americans at this moment. So I don't see that as an issue at the moment, but we'll have to wait and see.
Do you expect a number of the proportion of community spread versus travel-related cases to change over the next few days? Because now we're at 92% of travel-related cases. Do you expect like more community spread and less travel-related cases?
Just clarify, the 92% included contact with a case.
Yeah.
So 3/4 of them were travel, 1/4 were contact with a case. So as we have said, we're telling everyone to avoid travel unless it's absolutely essential. And people who are returning have been asked to stay in self-quarantine for 14 days. So I would hope we'll see less and less associated with travel.
I'm sorry, do we
Doctor?
have to move to the phone lines
Oh,
now?
Doctor,
But
just
you didn't answer
one
that
question. Just one last question. You have enough data now. There's a lot of data from everywhere, and putting that into the algorithms and the models. Where are we going with this?
So I've been asking even my people to go back and talk with the various modelers and to say, how does the Ontario experience thus far, 53 days in, fit in that? And as I was saying before, if you take the models, and even when we had our first case the end of January, people said, that test result is 2 weeks out, and that it's probably been 4 weeks out, and this has been going on, and you've probably missed it, and it's probably community-wide spread at this time.
Thank you. We have to move to the phone now. Please make sure to
So I'm saying, I'll just quickly, as we look at it, I think our containment worked well in that. We're going to see how this one goes with the large inflow of potential cases that may have contracted or picked up COVID-19 from their time in the USA. And as I said, those numbers are large, and so we have to work at this one, so we'll have to see. So I think we're entering, I would call it our third challenge as we go through this phase now. I think the aspect we have to look at, and you keep asking the term, and the term, it's community spread. I think I want to be clear, and Barb and I Dr. Yaffe and I were talking about this on the way up because we've been doing infectious diseases for a long time. When you have a case in a community, it means it doesn't have a travel history, it doesn't have an exposure to a case history. But it doesn't just happen spontaneously out of the blue. They got it from somewhere. The premise is they must have got it from some spread in the community. If they got it from some spread in the community, if you do your investigation, you find all those other people that have it and they got it from. You have to demonstrate there has been spread. That's easy to say, it's harder to do. And it takes a lot of public health work and energy in a time when it's already stressed and pressured. So I may have to accept the fact there's some cases out there, 2 or 3 or a few number, not a high percentage as Dr. Yaffe has alluded to, that they don't know actually where they got it from, and do they really have the time and all the energy to do the full comprehensive investigation to find if there's any others. The test case aside, if it's widely moving all out there, you should see it in some other ways. You should see it in our surveillance data with nearly 2,000 samples, because assuming it's out there and someone has it, they would probably develop respiratory symptoms. They might go to an ED department. They might get admitted. Or they might have ventured into a long-term care home and give it to someone and cause outbreak in the long-term care home. We're doing all that parallel testing, nearly 2,000 samples, all negative so far. So we're always looking for community spread. But just because you find a case that doesn't seem connected doesn't mean you have community spread, but it raises your concern. Do you actually have community spread? So this is part of the ongoing investigation we have to understand. So
To the phone lines. Jamie, I'm sorry, we have to move to the phone lines now.
There's a model here that's, you have the information for it. I'm just wondering what the model shows. How many people are going to be affected by coronavirus?
I would say my answer to that one was when we started the first one, Wuhan, someone said because if you missed it, by the middle of February you should expect 10 to 20,000 cases, about 600 deaths, and a large number of admissions. We didn't see them. When we had the next wave, and this one here, so how's this one going to work? So how well is our containment going to continue along with our enhanced social distancing? And how does that fit with the modeling? So I think you asked a very good question. I want to see how the modelers are going to work with that one. They know how it works on a naive one in all things being considered and their best prediction. But when they're reining in how well the containment process is working, the impact and the quality of the impact of the social distancing, because you can put it in, people may not comply. So there's a number of variables that mix in there. So I'm asking them, how's it going to look? So I haven't got those ones right now, but I know the projections that basically if you don't do it and it goes on, you follow a pattern, you end up with a certain number of cases. They talk about 60 to 70% of the population in the end getting it, and we know the mortality rate varies from different countries, and we know the hospitalization rates, and you can calculate those on a model basis if your presumptions and if your variables are fully understood.
Okay, we have to move to the phone lines now. Please make sure your phone is not on speaker. We'll take one question, one follow-up.
Your first question on the phone comes from Lucas Myers, News Talk 1010. Please go ahead.
Oh, thank you very much. I do have a question about the death, but first, I just want to ask about calls coming in. We received a report from someone who called in saying that she had all of the symptoms, but was told unless you've traveled abroad or live with someone who has, that they wouldn't be tested. So I'm just wondering if you're hearing that type of reporting, if that's in fact the case, if some of that information is coming by, that this woman said she has all the symptoms, was told, well, unless you've traveled abroad or live with someone who has, you're not going to be tested. Have you heard of that? And if so, how is that going to change?
Well, first of all, I think that it's important to remember that the symptoms of COVID-19 are very nonspecific. They're basically any upper respiratory infection. She might have influenza, she might have another virus, who knows what she has. I think currently it depends on the assessment center that she called or where she called. We are, as I mentioned before, working with Public Health Ontario to come up with a list of priority groups for testing. So far, the issue has been that we have had a shortage of the swabs that are used for testing, but that is being worked on very hard, and they will be up to a good supply very soon. And as I mentioned, the lab testing as well has been sped up. The bottom line is if somebody has COVID-19 and they're mildly ill, likely there will be no difference in what they're told to do. They will be told to go home and self-isolate and do all the things we talk about. Although I realize people like to know, but it would make no difference to that person's clinical care.
And thank you very much. And sorry, can I go again? Am I good to go?
Yes.
Oh, thank you very much. So my other question, sorry, speaking here, my kids in the background. So my other question was with regards to the death. Because on Sunday, Simcoe Muskoka District Health said that a man in his 70s had presented himself on March 11th and that patient was being treated. But also the individual was in close contact with a second patient who died on March 11th. So I just want to clarify that it's still the person who died, the 77-year-old man, is not the same as the man in his 70s who presented himself on the same day. Can I just get clarity around that? Because that seems a little bit confusing.
Actually, you confused me with your question, but anyway, Simcoe had reported a case in his 70s, and as well somebody who was a close contact of that person who passed away on March 11th. And the person who passed away is now the one we have found had COVID-19. We're still unclear whether he died with it or of it, but he did have it.
Okay, we have to move to the next question.
Thank you.
Your next question comes from Travis Deharaj, Global News. Please go ahead.
Thanks. Question for Dr. Yaffe. Ottawa's medical officer of health estimates that there are likely a couple of hundred, even maybe 1,000, that could be infected walking around that city that are just undiagnosed. Dr. Williams just said this is coming. You need to do something. You need to do it now, and you need to do it effectively. So then, is it not counterproductive to have services like the subways, which can be crammed during rush hour, still operating, places like malls still operating? And instead of an incremental approach, is now not the time to overreact as the World Health Organization has suggested?
I'm not sure I heard every part of that question. It was hard to hear. But the Ottawa MOH, I did follow up with her after I heard her comments, and her comments were based on modeling. So they may or may not reflect what actually is happening, because modeling, as we heard, depends on the assumptions that are put into the model. However, the measures that are being taken are addressing that. In terms of, you mentioned the TTC. I actually still take the TTC, by the way, and I found very few people are on it. People are very respectful. They're keeping away from each other. I think you have to look at the social and economic impact of every measure that you take. And some people in essential services still need to get to work. People still need to buy food. People still need to, do certain things to keep life going. And we do need, we do need to be able to get around. I'm not sure if I answered your whole question.
Somewhat. I have another question, though, on a different topic, and it's about testing. I know Lucas asked a little bit about this and was asked earlier. How many tests are available in the province right now? Are there enough, and are you going to be implementing other testing measures like we've seen elsewhere, like drive-through testing?
So when you say testing available, there's test kits and there's the equipment and the reagents that do it. So we have, as we said, we're trying to increase the reagents and test lab equipment from its current amount, approximately around about 1,700 to 2,000 a day, up to 5,000. The swab kits, we're looking at different varieties and trying to purchase more and more of those. So that has been a challenge because there's been large global demand, and we found out a lot of those basic swab kits are made in northern Italy. So that is a challenge in itself. And so we're continuing to look at supplies, and we feel confident that we will continue to increase that amount and expand the lab testing capacity as we proceed forward. So it's a moving situation, but there's different components, not just the kits. There's the reagents, there's the machines, and the training and staffing.
So would you say there are not enough tests in Ontario right now?
The fact that we want to get 5,000 tells us we don't think there's enough tests in Ontario.
Okay, we have to move to the next question.
Your next question comes from Allison Martel with Reuters. Please go ahead.
Thank you. Given that we have some test backlog in Ontario now, have you heard about hospitals seeing any increase in admissions or ICU admissions with respiratory symptoms?
That's a good question. Our command table, we have been looking at our data and our metrics with dashboards to monitor during this time. We also have our syndromic surveillance that we have historically done out of, it's called ACEs, out of Kingston. And we can watch the ebbs and flows of the respiratory in that one there. It would look like we haven't seen any major surge in the respiratory conditions at the moment in our hospitals in that regard. There's always little bumps and things with influenza, because we still have cases. I'm not sure if you've seen any direction with ACEs at the moment. And so we haven't seen anything, so that's the good news. And it hasn't had a major impact at this time in our emergency departments or hospitals and ICUs. Our number of patients in the hospital has continued to remain low, but that's not, doesn't mean we won't prepare in case we have more.
Thank you. Have you identified any cases through Sentinel or other surveillance programs, or is everything coming through diagnostic tests still?
All our Sentinel surveillance so far is negative, nearly 2,000 samples done throughout the province, either ED visits, parallel testing, or inpatient admissions, as well as long-term care samples submitted on a regular basis.
Thank you. Next question.
Your next question comes from Carly Weeks, Globe and Mail. Please go ahead.
Hi there. Thanks for taking my call or my question. So Alberta has said that it has 2 cases not linked to travel, and then they've the next day, like so within 24 hours, confirmed, yes, we have community spread. We're closing schools. We're tightening rules for mass gatherings. From what I'm hearing from you, like what you guys are saying, it appears as though you're really reluctant to say, yes, we have community spread, and here's what we're going to do about that. And I was just hoping you could expand on that a little bit, because we have 2 provinces now, BC and Alberta, and also the city of Ottawa, that are being very proactive about messages about and warnings about community spread. So just if you could address that point for me, please.
Right, and I think, I don't know the details all with our counterpart in Alberta, but I think, again, when you see the difference between community cases and community spread, when you investigate those ones there, a case that has no known travel or contact with a known case, then you have to ask yourself, how'd they get it? And if one assumes it's spreading through the community, then you should be able to investigate all the contacts, because remember, COVID is not just with casual passing by, it's droplet spread, and we know it tends to be very much a close contact. So you should take that case and assess who all those close contacts they had over the last 2 weeks. Now that's not easy, because sometimes you can't remember who you were talking to a few days ago. But you want to investigate that, and if there's community spread, if you find one case and you find that in those close contacts there's 5 positives and there's 5 more positives outside of that, you have evidence of community spread. And I'm looking for that demonstration to say, we have a case, and we actually followed up, and we found attached to that person 4 or 5 other cases, no travel history, no other contacts. It looks like the only one was through this person, so there's actually spread in the community. And these are sort of outbreaks within the community. But as I said, to undertake that in the time of this very intense workload is a difficult one, because it takes a lot of assertive action on that one there. So I think the assumption is, let's assume it probably is community spread, and on a precautionary basis, implement social distancing processes. And that's what we're doing in that event. But we're still waiting to see cases of actual examples of community spread. You see examples of that a little bit like in BC in the nursing home. That's a spread within that LTC facility. And that's an outbreak. And so we're looking for those, and we've had a couple we've monitored on that. So I don't know if that answers your question, Carly.
That helps. One quick follow-up. We've seen in the last couple of days there's very little information posted on the website, particularly around how the positive cases got infected. No information about travel or close contact or community transmission. It just says pending all the time. Why is that, and is that going to change?
Well, that is a reflection of the fact that when we get the lab report, we basically try to post it in a timely fashion, either 10:30 or 5:30, as soon as we can. The lab report goes to the local health unit at the same time as we get it. And so they then have to start from scratch and contact the case, find out, their travel history, who they've been around. The whole investigation starts at that point. So when we're posting it, most of that information is not available yet. But as soon as we get it, we add it to the website.
Okay, next question.
Your next question comes from Jessica Smith-Cross, QP Briefing. Please go ahead.
Hi, how many COVID-19 patients are in hospital now, and how many have required being intubated?
I don't have that data right now.
I know there's, we had the one who unfortunately passed away, and there's a couple of others in there. There's some we're waiting for some status updates on. I believe there is one intubated in this time, and There was one who was not doing well, but now has recovering. So there's different reports we have to get back from the hospitals on that basis there. So I don't think we either of us have those numbers right on hand right at the moment. We could seek to get them, but we don't report on them regularly yet. Those are kind of the metrics we could report on.
Follow up?
It's about the website. The information about whether a person is in hospital or isolating is posted on the website, but it's only for the last day. Have you considered making all of the data on all of the 185 cases available so we know when it is updated in terms of the means of transmission and the status?
We've talked about that, and that's one of the things when you get into these larger ones, once you start getting into, like we were seeing 40, 50, 60 new cases a day, and you're adding, and then you're going up to from 170 to larger numbers, whole spreadsheets over the whole history becomes a very complicated thing. And how does that really help inform on the outbreak in that if someone wants to know if someone's in hospital X or Y? So we're looking at how we should, as Dr. Yaffe alluded to, get enough data out expeditiously without tying up with long times to fill up all the boxes, and when they don't actually change the actual response to the outbreak or inform the public in any solid way. So we're trying to, look at streamlining and making sure we can still get the data out so that the public are kept up to date on some ideas of how the whole outbreak is progressing.
Next question.
Your next question comes from Emma Paling, Huffington Post. Please go ahead.
Thank you. I just want to make sure I understand the timeline between when people are tested and when they get the results. So these confirmed cases that we got today, would those people have been swabbed yesterday, a couple days ago, last week?
I can't answer specifically for today. I know that we were aiming for them to receive the results within a day. I think right now with the backlog, it might be taking a few days, but we're aiming for 1 day.
Follow up?
Okay, thank you. And then I just wanted to clarify something else that you said earlier, Dr. Yaffe. You said 92% of new cases were related to travel or close contact. Were those the new cases today, or is that the total of all cases?
That's the total of all the cases so far.
Okay, thank you.
Your final question on the phone comes from Victoria Gibson, iPolitics. Please go ahead.
Hi, my question's for Dr. Williams. You mentioned that the Emergency Act increases your ability to move in certain actions. We know the province is ordering closure of places like libraries and schools. So I'm wondering if there are any other powers the province now has that aren't yet being utilized but you think might be useful over the coming days or weeks.
There are other powers and aspects that they can exercise through the cabinet and the premier. Premier, in his speech this morning, alluded to some of those activities that they're undertaking in that light. And there's various economic ones and other ones that can be exercised, powers that I don't have that they can undertake in there. And I think if you want more details, we can direct you to certain sites to understand more how the Emergency Measures Act works and that, so we can report to try and get that information to you in there. As it's not, I think this is the second time we've used it since, first time since 2003. So there's various powers in there that it gives to the cabinet and the premier.
Follow up, and this is the last question.
Yeah, just to follow up on that, are there any, when you read through there, I've seen the act, but are there any that stand out to you as having the potential to help with public health, potentially around increasing resources in hospitals or anything like that you see as valuable?
Yes, I mean, with the action with the social distancing, where I can recommend or suggest that they can make it required in there, as well as the causing no more gatherings of over 50 and those aspects there. So those are powers and authority that the Act gives, that mine are public health recommendations in that, and there's a difference there. Also, they can allocate facilities and resources if they need it to respond, and that could be more resources for public health. There could be some things related to facilities and different equipment and materials and stuff that under the Act they can acquire in a very, I would say, efficient manner to deal with any response. So it could improve the services for public health and the public health response overall. That's why it was enacted.
Okay, thank you very much.